Hello everybody. Today I want to take a look at John Oliver's advocacy and case for Medicare-for-All, as well as take an at-large look at the US healthcare system. So this will be a particularly lengthy video. And to clarify, I know that I'm a little late to the party. Namely that the video was released in February while I'm here, social distancing, and talking about the video in May. But I just started this channel and healthcare was a topic that I wanted to cover. So without further ado, let's get started.
Well, right now we have what's called a multi-payer system. What that means is maybe your healthcare is covered by private insurance purchased by you or your employer, or maybe it's covered by a government program like Medicare or Medicaid, or maybe you're one of the 27 million Americans with no insurance, in which case you're fucked. The basic idea behind Medicare-for-All is that all of this will be replaced by a government-funded single-payer program. And the goal of universal healthcare coverage is extremely appealing. Both Bernie Sanders and Elizabeth Warren have put out versions of Medicare-for-All, but other Democrats have been much warier of it, and conservatives absolutely hate the idea.
So I want to get into a bit of a general framing here, because the framing that John Oliver gives here will actually play a major role in his advocacy for Medicare-for-All. Now, John Oliver essentially introduces the idea of multi-payer versus single-payer, and then goes on to explain that Democrats like Elizabeth Warren or Bernie Sanders are for Medicare-for-all, while Democrats like Joe Biden or Pete Buttigieg are wary of it. As a quick side note, they support a public option, which, as the name suggests, is simply a public insurance option that doesn't remove the private insurance industry, but simply adds another economic actor. And finally, he goes on to say that conservatives hate Medicare-for-all. Now, this is true enough, but still incredibly misleading in terms of the actual framing of the debate. While it is the case that the US healthcare system is flawed and needs reforms, it's largely unclear as to why the jointly exhaustive option is that of a single-payer system, as John Oliver will soon sell us. That is to say, the framing that Oliver gives seems to be multi-payer versus single-payer, as though a pure market approach to healthcare is in the same boat as a public option. But a more nuanced question would be single-payer versus other reforms to our current healthcare regime, and this is something that Oliver will never talk about. As I'll later discuss in the video, there are market-based approaches which seem to have a greater degree of utility that, even in the worst case, seems to outweigh any potential disutility. But it's important to recognize the true framing of the arguments out there, and Oliver blips over the nuance of the actual debate throughout the video, and seems to use a lot of the issues of the current system as exclusively advocating for a single-payer system, hence the framing of multi-payer versus single-payer. So why do we really care this much about clearing up the framing? Let's say that we were to play around and pretend that for the rest of the entire video, John Oliver was to sell us Medicare-for-all as perfectly better than the status quo. It would still not prove why it is the best solution. To the extent that all he has done is prove why it is better than the current state of US healthcare, he hasn't really proved an awful lot, especially if we buy his own arguments on how bad the status quo is. So even if we give John Oliver here the absolute benefit of the doubt, the lack of comparative analysis throughout the entire video doesn't get us to the main question. Why is Medicare-for-all the best possible alternative, and not why it is simply an alternative? The framing that Oliver gives may be helpful for answering the latter, but not the former.
Our system is badly broken, and I'm not just talking about the 27 million without health insurance, but the nearly 44 million more who are underinsured, people with high deductibles and co-pays that can end up bleeding them dry. The majority of people who file for bankruptcy cite medical expenses as a factor, and you probably already knew that deep down from just how often you see GoFundMe campaigns online.
Now, there are a couple of things to unpack here. First, the issue of uninsurance and underinsurance, and second, the issue of medical bankruptcy. Now, I want to address the first issue of underinsurance and uninsurance at length, because it'll be a common theme throughout a lot of Oliver's arguments here, and he'll use it oftentimes to weigh the benefits of Medicare-for-all. So a good discussion of what uninsurance really means to the debate is necessary, and Oliver doesn't provide it. So without further ado, let's do it ourselves. Now, to start, we can simply refer to the previous comments I've made on the issue of other alternatives. That is, if other alternatives can gain the same coverage as Medicare-for-all, where is the unique offense that Medicare-for-all has? But even if we want to ignore this argument and say it has no validity, we still need to answer the question as to how bad is being underinsured or not insured at all. Well, the details dictate the answer. For instance, studies like that from the National Academy of Medicine and the Committee on the Consequences of Uninsurance, which examine many other studies and papers, find that health insurance coverage has a positive correlation with health outcomes across numerous domains, from screening services to cancer care to chronic disease care. However, these studies are largely based on the current quality of treatment and expanded coverage with regards to the private sector, not clearing up the impacts of government-induced universal coverage. While it's no doubt that coverage increases under Medicare-for-All dramatically, the question is whether or not the quality of care remains constant, given that patent protections are largely gone, provider payment rates need to shift, and market consolidation will be an inevitability. Therefore, for Oliver to properly weigh coverage later on in this video, he needs to give us a little bit more work in proving that quality change associated with coverage is not an issue. Why is this the case? Given that Medicare-for-All will create huge amounts of structural change, it is likely the case that there will be huge shifts not only on the demand side, but the supply side, namely questions of producer surplus, R&D in the market, and enticing new entrants. But these changes go largely unaddressed by Oliver aside from a blippy argument he'll make later on needing to balance the effects of innovation. But we still get no solvency, so to speak, in terms of these issues, and it remains rather ambiguous throughout the entire video as to whether the coverage that people receive under Medicare-for-All, and that is largely standardized, will outweigh the status quo. Now, you may ask, well, isn't some coverage better than no coverage, even if it is comparatively worse? The answer to this question is whether government-induced universal coverage will actually lead to better health outcomes. Sure, you can visit a doctor, but if you aren't getting proper diagnosis and treatment and your health isn't changing positively, it isn't making a difference. That is to say, people will definitely increase their use of healthcare services, but the question is whether it leads to better health conditions. Therefore, two questions have to be answered. First, is there any change in non-deferrable treatments? In essence, are people dealing with such high costs that they are literally foregoing treatments that simply shouldn't be foregone and are life-saving? And second, for the case of deferrable treatments, are people seeing any bettering health outcomes? Just because somebody has de jure access to health improvement procedures doesn't mean that they have de facto access to it to the extent that it doesn't actually improve their health. First and foremost, people who have non-deferrable conditions are likely not going to change their use in any significant amount. Why does this make sense? To put it simply, when people decide to use healthcare, they engage in a cost-benefit analysis like they do in any market. The main question being, is the disutility of cost likely to outweigh the utility of healthcare? Now, people may think that this is largely draconian, but when we get into the world of moral hazard and other health economics phenomena, you can see that this is a necessary regulatory mechanism that prevents strain on the medical industry's capital and ability to provide effective treatment. Of course, this is largely logical argumentation, but there is also empirical evidence to suggest that non-deferrable admissions to hospitals see no change regardless of coverage created by the government. In fact, a study conducted by David Card, professor of economics at UC Berkeley, named Does Medicare Save Lives, measured the changes in hospitalization and health outcomes for senior citizens before and after 65, namely focusing on non-deferrable conditions which had the same admission rates during weekdays and weekends, presumably showing that there is a relative inelasticity in their demand and emergency status. The study ultimately concluded that after patients were entitled to near universal care, mortality rates remained relatively unchanged for people with non-deferrable conditions. Card also provided analysis on other studies which claimed to say that there are some mortality rate decreases after Medicare program eligibility, which for some cases was true. However, this decrease was not actually largely due to people who were previously uninsured, mitigating the salience to this idea that dramatic changes in coverage lead to dramatic changes in health outcomes, a correlation that Oliver will later imply, and that, as the study concludes, the small decrease in mortality rate overall is not really understandable, and the cause of this effect still remains largely unclear. Now, you may then ask, well, what happens to cases of lower urgency yet great gravity, such as forms of preventative care and diagnosis? Well, as you will later see on in the video, we will actually address this question with the issue of moral hazard and adverse selection, so I'll save that for then. But to give a hint, it's not a pretty picture for Medicare-for-All. Now, what about medical bankruptcy? Well, Oliver's argument seems to simply be that prices are so high that they are contributing to bankruptcy. But the simple question that yields a very simple response to this argument is, first, what does it mean to be contributing to bankruptcy? For example, if someone is jobless and goes bankrupt, sure, medical bills played a role, but the bigger issue seems to be that the person doesn't have a job. Therefore, we need a better separation of the variables. And second and simply, how is this statistic found? To best understand this, we can take a look at Oliver's own source. The main way that the source goes about getting to this near 60% statistic is by asking people if medical expenses had contributed to income loss, if they experienced medical-related financial stress, or, quite bluntly, if they had gone bankrupt due to medical expenses. Anybody who had reported affirmative to these statements would be stated to experience a medical bankruptcy. But there's a categorical difference between a medical bankruptcy, indicating an implied causal link between bankruptcy and medical bills, and a regular bankruptcy where somebody had to deal with medical payment stress, meaning that while it was somewhat a factor, it doesn't pass the definition of a medical bankruptcy. This issue is empirically based as well. A 2014 study by the Consumer Financial Protection Bureau finds that while nearly 20% of Americans have substantial medical debt, only 1% of Americans file for personal bankruptcy. Now, an even greater analysis of Oliver's own source is provided by Carlebs-Dobkin et al. In Myth and Measurement, the Case of Medical Bankruptcies. At the very least, the role that medical bills play in bankruptcy is severely overstated, and is actually a very small factor in bankruptcy.
And to be honest, I personally think there is a lot to be said for Medicare-for-All. So tonight, let's take a look at it. Not the politics of whether it can pass, but what it actually is. And whenever the subject comes up, you tend to hear three major criticisms of it concerning cost, wait times, and choice.
A brief note here is the question of quality coverage is most likely a bigger question. Presumably, Oliver thinks that wait times are a major element of quality, but there's also something to be said for innovation in the market and the actual quality of treatment at the point at which people access it.
Because critics will tell you that Medicare-for-All will simply increase the federal budget too much. Medicare-for-All would undeniably be expensive, but that fact needs a lot of context around it. For starters, it would increase the federal budget, yes, but it would also eliminate employer spending on premiums and your spending on out-of-pocket costs. Now, would those balance each other out? That is a good question. The answer is no one can possibly know for sure. There are just too many variables involved. The Times asked 5 prominent experts to estimate national healthcare spending under Bernie's plan, and they compared that to what we spend now. And the results range from it would actually cost us less, to it would cost about the same, to it would cost a fuck of a lot more. And I know that extra shading does not look like very much, but believe me, it's a fuck of a lot.
Again, there's a lot to discuss here. First, let's start with Oliver's argument that there is a balancing effect. Of course, while this is true in theory, the application of the argument to the question of whether or not Medicare-for-All will cost more or less based on these 5 different studies is largely flawed. To start, most of these studies already take into account this balancing effect, which is why that $32 trillion price tag already takes into account savings on deductibles, co-insurance, co-payments, and employer payments. For instance, if we're looking at the Urban Institute's analysis of Bernie Sanders' Medicare-for-All plan, we actually find that it is the case that this balancing effect is taken into account. Namely, the fact that individuals currently enrolled in plans with high out-of-pocket costs would see a positive change, and that average employer contributions would likely decrease as well on the comparative of the status quo. In fact, it literally notes this on the 3rd page of the study, so it is the case that exogenous variables are understandable in terms of their impacts on calculations. The main question is the methodology behind each of these studies and what assumptions they operate on. Now, only 2 studies say that the cost will be less. However, a closer look at Oliver's own source and these studies on their own shows that they are more the result of underestimation due to faulty methodology. There are a couple of questions that need to be answered to understand why the 2 more generous estimates are actually likely to be understated. The first is with regards to payment rates, or simply put, how much money is being compensated to healthcare providers. It is likely the case that government spending would have to take a significant increase. Why is this the case? This is due to the fact that private spending would be significantly lower, namely that co-pays and deductibles are gone and payment at the hands of employers is gone. However, it is the case that the government has to make up for this difference by a significant degree in order to ensure there is adequate producer surplus for healthcare providers. Because at the point at which healthcare providers are not having such economic surplus, they are likely to leave the market, and thus lowering the supply of healthcare for individuals. Charles Blahouse, out of the Mercatus Center at George Mason University, said himself, and as according to Oliver's own source as well, that he used the current Medicare rates to calculate the cost, although he said that the rates would have to increase. After doing so, the cost would likely go up. But how do we know this? Blahous himself actually reran the calculations and found that spending at around 111% of Medicare, around the average right now, the total would shoot up by 1.5% of GDP, putting his calculation between that of the Rand Corporation and Kenneth Thorpe. But let's say we don't trust this evidence. Even if we want more, the Journal of Clinical Pathways found that in the status quo, using data from payment rates in California, Medicare paid for an estimated average of 79% of hospital costs, while private insurers paid for an average of 165% of hospital costs, meaning that increased payment is highly likely given the fact that I don't think progressives want to bankrupt medical providers, especially if the goal is to maintain the same or similar quality coverage and availability. The second question is with regards to cost savings on the hands of the government. Now, Gerald Friedman, the most generous evaluator, assumed that there will be the largest cost savings on both prescription drugs and administrative spending. Specifically, he stated that drug spending would be reduced by nearly 31%. But, as the source notes, the only way this is likely to occur is if you have lower availability and coverage of drugs. That is to say, lower costs come with greater consolidation of the market. So why is this true? This is due to the fact that in order for the government to be able to gain effective leverage in drug price negotiations, they would likely have to make major decreases in the number of choices for drugs, meaning that some individuals would not be able to get access to the drugs that they want. Why? Because, to put it simply, the more providers there are, the more considerations there are, and the greater difficulty there is in standardization for a federal program. And Oliver also states that this consolidation will occur by the end as well. However, at the point at which this happens, drug innovation takes a significant dip. The reasoning is because even if consolidation is moderate, it is likely the case that higher prices cannot be charged to justify new amounts of innovation by virtue of government negotiations. As such, drug providers are less likely to invest into innovative drugs due to the fact that they cannot make up for the high fixed costs of R&D and the commitment that must be made by charging higher prices. If we want to think about this in terms of risk premiums, the return on a risky investment into high volumes of research is unlikely to justify a choice of this comparatively risky investment over a relatively risk-free continuation of current production. But, as such, drug innovation takes a significant decrease. The importance that when drug innovation decreases, you have collapsing quality. So it is likely the case that if progressives also care about maintaining any amount of quality, this consolidation will not occur to such an extreme, and the balancing is less likely to be so generous as Gerald Friedman assumes. Now, this relationship between drug profits and future research is also empirically seen, as put by Joe Kennedy from the Information Technology and Innovation Foundation, quote, "For the issue of pharmaceutical drugs, an overwhelming body of academic research shows that price controls will significantly restrict the number of new drugs in the future," end quote. Of course, while price controls aren't the exact policy, the macroeconomic effect of these negotiations will largely match that of price controls. Now, of course, there is the critical element of current patients, and there has to be meaningful weighing done as to who is more important, the patients of the long term or the patients of the short term. However, I think that the weighing comes down to the patients of the long term for a couple of reasons. First, there are more people in the future. That is, the long term holds a greater array of individuals and people given current population growth projections, and as such, future shortages and cures will ultimately make a difficult life for many of these people on a much greater scale. Second, if we think about the impacts of Medicare-for-All, according to the same paper, it is also the case that innovation decreases in the short term. That is to say, a world in which drug producers find out about Medicare-for-All being implemented over time is a world in which they will significantly reduce the volume of current investments into research. This also isn't aided by the fact that patent protection reductions are integral to Medicare-for-All, reducing the chance of innovation even further. So even if we want to give a greater benefit of the doubt and say that research will still remain the same in terms of the capacity to do it, the incentive is significantly reduced because drug producers aren't guaranteed intellectual property protections. In essence, this is the classic case of a positive market externality, where one firm would do all of the research, but others would also bear the fruit of the research. At the point at which this happens, incentives for R&D significantly decline. Of course, one may then ask, well, is it the case that Friedman's calculations would be more or less than the status quo when corrected for this? The answer is largely complicated. After reading through his entire study, he makes numerous assumptions that seem to increase the generosity of considerations. And considering the fact that to incentivize innovation, you need to grant a firm a monopoly through patent protections, it is highly likely that in a world in which the cost is far less, the quality has also collapsed by incredibly large amounts, and innovation, namely, has collapsed by incredibly large amounts. But to add on to even more weighing, it is also the case that with innovation, the people who are the worst off receive the greatest benefit. namely that according to the National Health Council, nearly 40% of the population suffers from chronic and incurable diseases. Therefore, I'm going to play around and give Oliver here the complete benefit of the doubt. Let's just pretend that there is literally no change in current quality minus innovation, and that only coverage increases. In fact, play around and say that the quality minus innovation gets better for some reason. Even if this is the case, insofar as it comes at the cost of these 40% of individuals who suffer to the greatest extent, this is not a cost that I'm willing to take, especially because they suffer from diseases that can only be mitigated at best, and oftentimes there are no cost-effective treatments which innovations seek to better. That is, boosting utility for a given price or lowering price for given utility. Now, these people are the most important, and to the extent that they are unaddressed, Medicare-for-All isn't a meaningful solution, especially when their costs make up nearly 75% of healthcare costs. Now, I know that this is a bit of a rant, but it's paramount to drill this idea that these extremely generous considerations for cost are propagated off of major reductions in quality that most rational individuals are unlikely to concede. Now, before I move on, I want to quickly look at a major element of this discussion: drug prices. While I just mentioned the need for higher prices and monopolies to justify drug innovation, some might say that there's a huge disconnect between revenue and R&D, and might wish to discount the argument made. Namely, people might point to a litany of supposing empirical evidence showing a disconnect between drug profits and R&D. But this actually brings up an important element of the discussion as to why many of these studies don't get this point right due to methodology. So I want to also take a look at this to discuss not only the evidence brought in, but other evidence that exists that points to the counterfactual, a disconnect between drug prices and R&D. First, we get the common argument that other countries, namely those in Europe, are able to have R&D without high drug prices, and that drug price controls in these nations have still led to comparable outcomes to the US in terms of drug spending and intensity of research, which is first, false, given that the US pharmaceutical industry leads OECD countries and other US industries in R&D intensity, measured as the level of R&D over the total gross domestic product added by the industry. But even if we want to ignore this, there is the added impact of the fact that European countries are still reliant on high drug prices, but not in the way that you think. First, many drug producers overseas are also involved in US markets, and given that they are unable to make up for the fixed costs of R&D at their home country, they make up for it by charging higher prices in the US, which makes sense given the incentives and capacity to do so. But can we see this empirically? Yes. The US is responsible for half of the globe's drug consumption, so presumably, roughly half of the funding for rounds of innovation should come from the US. But this isn't the case. US consumers actually make up nearly 70% of global patented pharmaceutical profits. But it doesn't stop there, as according to the Information and Innovation Technology Foundation, there are numerous issues that exist out there with studies that seek to prove that drug prices are nearly unjustified. These issues come in the form of measuring profits and prices. To start with prices, while still high, as historically seen since the 1990s, they have been significantly overstated, leading to a greater than necessary salience. Why is this the case? Inflation measurements by the government have been problematic given the fixed basket method of calculating inflation that doesn't capture the dynamics of the market, namely price indexes being overestimated. Firstly, new generics are often not included in the fixed shopping basket of drugs that is used to create drug price indexes, despite the fact that their entrance would push the market towards a more competitive equilibrium. So how will this impact calculations? Well, as according to the study, properly accounting for the entrance of generics would mean that drug prices actually fell in 3 of the last 9 years from 2019. But even more, without account for new products, these price indexes are unable to capture the fact that real drug prices can actually decline when better drugs are introduced, namely where the dollar value is the same, but the actual quality and utility has shifted in favor of the consumer, which economically would boost the purchasing power of the dollar and lower real price. But this is left unestimated in many calculations. And the issues don't stop there with regards to how many studies and papers out there fail to prove the seeming disconnect between R&D and profits. The calculation of profits that people generally cite significantly overstates them, and therefore is used to show the seeming gaps between research and profits. Many studies and papers significantly overstate profits because they ignore standard accounting practice when it comes to the amortization of R&D and marketing for pharmaceutical companies. Namely, that the useful life of R&D and marketing is over several years, making sense for this to be something taken into account. However, standard practice by the pharmaceutical industry has been to simply write off research as a one-year phenomenon. While sure, this may better capture cash flows, it doesn't represent standard accounting practice and the actual useful life of the asset that is R&D over a period of time, meaning that the rate of return on assets is significantly overstated given the ratio of profit to resources is skewed towards profit. So what is the quantitative scaling of this? Is this just a mitigatory point? Well, actually no. As reported by the Congressional Budget Office, when standard accounting practices were actually used, pharmaceutical profits were, quote, somewhat larger than other industries, but not double that of other industries, as some studies and papers have stated. And there is much more. Using the link below, you can see Joe Kennedy's work on drug profits and their positive impact on research, to see why it is the case that many have been quick to deny the claim that US pharmaceutical profits lead to better innovation, but not have the proper methodology to empirically lay the foundation for these claims.
Let's say, just for argument's sake, our overall spending did go up. We would be getting a lot for that money. Remember, 27 million more people would be covered, and they'd be covered well. Bernie's plan is incredibly generous. It covers vision, dental, long-term care, and drugs. In fact, Medicare-for-All is a misleading title because Medicare requires some co-pays and out-of-pocket expenses, and Bernie will excitedly tell you his plan eliminates those.
Under the Medicare-for-All bill that I wrote, premiums are gone, co-payments are gone, deductibles are gone, all out-of-pocket expenses are gone.
He's right.
Now here, John Oliver decides to give us the benefit of the doubt and says that Medicare for All, even if costing more, will be outweighed by all of the benefits that are afforded, especially due to the fact that coverage under Medicare for All will likely increase. In essence, he is simply stating that the increased coverage that you receive and the good coverage will outweigh the costs. Now, as I mentioned earlier, Oliver essentially states that these 27 million people are important. The response is simply how important, and as we've addressed, the coverage that people get is not effective for a couple of reasons. First, in the case of non-deferrable treatments, there are no changes at best for Medicare for All, assuming no quality change. And in the case of deferrable treatments, it is likely that they see a significant reduction due to the market consolidation that will have to occur. So there is the chance that this coverage will not help individuals, or that they will already have to make huge payments in terms of the taxes that exist. Why is this the case? Because as we've already shown, it is the case that cost increases. And so if cost increases, the taxes that individuals will have to pay will increase. Or if we want to bring in a curveball and say that modern monetary theory, under the brilliant leadership of Stephanie Kelton, will pay for the plan, it is likely the case that there will be major inflation, which itself will act like a tax. But important to note is the question of moral hazard. Namely, that if Medicare for All is as generous as it is also likely the case that moral hazard will ensue. Why is this true? This is due to the fact that without any price signal or cost regulatory mechanism, people are likely to use healthcare services without bearing any cost. Given, however, that people are incredibly risk averse when it comes to their health, it is likely the case that people will overuse the healthcare system without consideration for the cost that they will bear. Why is this the case? Price signals help reduce asymmetric information. If a healthcare provider is having difficulty meeting the demand for a certain treatment, they may raise their prices, signaling that the treatment is expensive for them. Now, we don't necessarily have to infer what the increase in price means, but rather that it is too much for us and thus that we don't rely on the service. However, these price signals don't exist in a Medicare for All world. This also connects back to the cost-benefit analysis that individuals go through. No cost means that individuals will always opt for more benefit, which in this case is the healthcare service, and additionally, even with diminishing marginal utility, it is still likely that people will use healthcare because there's no disutility to place it up against. Now, some may counter-argue that there does exist some opportunity cost, because people have to go for a checkup and take time out of their day. However, firstly, people are incredibly risk-averse, as we mentioned, when it comes to healthcare, which reasonably preempts this argument given the fact that in the eyes of individuals, this opportunity cost is consistently outweighed. But even if we don't buy this argument, it is also the case that it's unclear as to why this is exclusive to healthcare. That is, engaging in any market will always pose some opportunity cost, as literally any action or activity has an opportunity cost, meaning that it is not enough to prove that opportunity cost exists, but rather to prove that it is not marginal. So how will this moral hazard play out, and what are its impacts? Important to note is that moral hazard is not simply people using more healthcare. This will likely occur with any subsidy. However, the point is that people will use more healthcare than necessary. More than necessary is the key operative here, due to the fact that it is indicating that there is a reduction in total surplus within the healthcare market. In other words, the additional value of a certain healthcare product or service is less than the marginal cost of that healthcare product or service to the producer. Additionally, if people use more healthcare with no significant changes in health outcomes, this indicates that we have such a reduction in this total surplus as there thus isn't any justification for it. Empirically speaking, we can see this as well. According to a study by Liran Einov, a professor out of Stanford University, and Amy Finkelstein out of MIT, an analysis of many prominent papers and studies find that moral hazard exists when it comes to the healthcare market. Even if we don't buy this evidence, a study called Distangling Moral Hazard and Adverse Selection in Private Insurance, researchers David Powell and Dana Goldman found that for an analysis of 3 different plans offered by a firm in different levels of generosity, the most generous plans had a difference in the level of spending for which moral hazard accounted for 53% of it. Presumably, in a world in which there is a plan with the level of generosity of Medicare-for-All, as John Oliver puts it himself, moral hazard increases by an incredibly large amount, meaning that we have this reduction in total surplus, but namely that there aren't any changes in outcomes. So why does this matter? When moral hazard occurs, there is a greater than necessary cost to the producer at a little benefit to the consumer, meaning that providers are likely to lose vast amounts of money in these compounding marginal costs, only increasing the need for the government to increase their costs furthermore, likely taxing individuals and consumers as we speak, and making a literal sloppy Joe of macroeconomic failure. In essence, even if there are increases in coverage, there is also the chance that individuals end up paying more due to taxes, not really affordable so to speak, pay for it by inflation, which reduces the purchasing power of people who are low income and spend to greater degrees, or that suppliers exit the market, meaning that it will be harder for individuals to get their hands on care.
Bernie's plan isn't just more generous than most current private insurance plans. It's more generous than the policy of any single-payer country on Earth. And there is a good case to be made that even if national spending wound up higher, we might wind up wasting less. Right now, a lot of our healthcare spending doesn't go to healthcare. It goes to administrative costs that come with having a vast insurance industry. That is clearly wildly inefficient. And consolidating all health insurance under one roof would give the government far more leverage to negotiate prices down. Because look, it is no secret, prices for procedures and drugs are out of control in the United States. It is so bad, one insurance provider in Utah recently started offering some of its participants cash if they were willing to travel a little further than their local pharmacy to fill out their prescription.
The argument that John Oliver is making here is that in a multi-payer system, you essentially have higher than average wasted costs due to the fact that insurers and healthcare providers are in a constant tug of war that raises administrative costs and as such wastes resources. This isn't anything new. In fact, Bernie Sanders has made the point that private insurers spend far more on administrative costs than a federal program like Medicare, for instance. So I want to address this common argument before bringing it back to Oliver's central point of consolidation. The specific argument we get from Bernie Sanders, and commonly from other single-payer advocates, is that while private insurers spend nearly 16 to 18% on administrative costs, Medicare, as it currently stands, only spends roughly 2% on administrative costs, ergo better efficiency. However, there are a couple of issues here. First, simply taking administrative costs as a percentage of spending is not a good metric of waste, especially if those forms of spending are likely to lead to better coverage, such as costs of administrative infrastructure that leads to expansion for insurance providers. But even if you don't buy this, there are more issues with this argument. We can actually see that other administrative costs will likely make up for any potential benefit in terms of negotiations. Namely, that according to the American Hospital Association, health systems, hospitals, and PAC providers had to pay $38.6 billion per year for regulatory compliance along 9 domains, containing nearly 629 discrete regulations. On a per-patient basis, this equates to $1,200 per patient. The vast majority, 63% of the regulatory burden, comes into the COP adherence policy, or Hospital Conditions of Participation, and was responsible for nearly 2/3 of the allocations of employees from delivering care. This COP adherence policy essentially dictates whether a provider can accept Medicare beneficiaries or not. In a Medicare-for-All world in which you don't bankrupt providers and keep a healthy supply of providers, regulations imposed by the government are, first, applied to all of these providers, and second, have to be significantly increased to deal with massive increases in coverage. So how does this apply to John Oliver? First, we don't get any empirical scaling of this argument, making it largely unclear if other regulatory burdens, in terms of those on providers, make up or mitigate this advantage or not. But second, he admits to the fact that consolidation has to occur, which triggers all of the negative impacts we have talked about in terms of innovation and supply within the market. As such, you can just weigh the 40% of the population that doesn't have access to cures over others now. Because even if we want to give John Oliver here his absolute best case scenario, ignore all the previous arguments, if you save a huge amount of money on administrative costs, to the extent that it comes at the cost of those 40% of individuals who are the most vulnerable and need the most help due to their chronic and incurable diseases, Medicare-for-All isn't really achieving the impact of being a very equitable system.
Under Medicare-for-All, the government would be a much stronger negotiator. Now, you wouldn't want it to set prices so low that it stifles innovation or bankrupts doctors, but that is a balance that you would need to strike. Overall, you can't definitely say that it would be more expensive, but even if it was, I personally would argue that it's worth it. And either way, cost is a lot more complicated an issue than just going on TV and saying $32.6 trillion.
I think that it's funny that Oliver brings in the balance that you have to strike, because the point is that while this is true, the optimal balance is where prices are higher, and to an extent that I'm presuming Oliver won't support. If you want to have innovation, you need to permit some amount of monopolization to avoid this positive market externality, or allow businesses to raise prices to very high amounts to justify the incredibly high fixed costs of research and development. Namely, that the risk premiums for these businesses begin to collapse in John Oliver's world.
The next major criticism of Medicare-for-All concerns wait times, specifically that it would result in rationing and delays to care.
If you think it's fun to wait in line at DMV, you're going to love Bernie Sanders' wait times for Medicare-for-All.
It leads to the kind of care that people now have in England or Canada, where you have to wait in line.
Just take a look at Canada or the UK. It means long waiting lines. It means people not getting the health treatments they need.
As with cost, comparisons of wait times are very complicated. For one thing, the international wait times that you hear about most often are for non-emergency surgeries, such as knee replacements. And while yes, people in other countries do sometimes have to wait slightly longer for some care, it's not like Americans aren't having to do that right now anyway. Americans are just sometimes forced to wait due to the expense. About half of US adults say they or a family member put off or skipped care in the past year because of the cost. And about 1 in 8 say their medical condition got worse because of that delay. As for the uninsured, they can wind up having to wait on a literal line seeking care with aid groups like Remote Area Medical, an organisation that travels the country setting up mobile clinics to treat people for free, and which draws massive lines wherever it goes.
Again, there is a lot to unpack here. I think that a reasonable summary of this argument is that while people may face longer waiting times in other countries, it's not that the United States offers more efficient care in the status quo, but rather that people decide to forego care due to cost. Essentially, the comparative is longer waiting times versus foregoing care due to cost. First, it's important to recognize that people foregoing care due to cost is not a categorical bad. That is, it is bad at the point at which healthcare services are being foregone and having negative impacts on health conditions. If somebody skips out on a more elective or elastic operation, but there is no negative impact, there has been no disutility, and we have been able to avoid the negative of the unnecessary cost on the healthcare provider. Now, you may say that we don't want people with more urgent forms of care having to decide between restrictive high costs and getting access to urgent care. And I absolutely agree, but this only further cements why price is important in the healthcare market. What do I mean by this? If a provider has high average total costs, it is likely the case that they will have to charge higher than average prices in order to make any type of profit, expand capital, and lower the costs behind the service. Therefore, if there are higher prices in the market, these act as price signals that the cost behind the service is incredibly large. However, when it comes to the world of Medicare-for-All, such price signals do not exist, triggering the impact of moral hazard that we've already proven exists in the healthcare market. So what does this mean? If people weigh the utility of medical care over that of the cost, it is likely the case that there exists urgency. But if people are dealing with largely elastic operations, such as knee replacements for instance, it is likely the case that without price signals, people who need the more urgent forms of care end up suffering. Now, why is this true? This is due to the fact that the demand for these more elective operations is far more elastic. meaning that when price doesn't exist, there is a huge upshoot in demand. If you're a healthcare provider, there will be huge amounts of money that end up going over to these procedures, namely the fact that capital will get pulled away from the more urgent forms of care, since there is a natural mutual exclusivity that exists when it comes to capital and where it is used. In essence, a dollar spent on knee replacements is a dollar that could be spent on MRI technology. Now, you may say, well, aren't they making money for every knee replacement or every elective operation? In essence, aren't they able to take their profits and move it to more urgent forms of care? The answer is no. Marginal costs rise exponentially as quantity supplied increases, meaning that when there is a huge upshoot in demand, there is an exponential increase in marginal cost, and thus that prices have to increase and cost has to increase. This isn't aided by ambiguous change in health outcomes. As such, the real question that should be asked by Oliver is if people foregoing care due to cost is having negative impacts on their health outcomes. If health outcomes remain largely consistent despite lower uses of care, it is likely the case that these costs were not needed in the medical industry and that they didn't cause capital to be pulled away from people who are in desperate need of medical care. So what is the answer to this question? Oliver's own source actually shows that nearly 90% of people who avoided medical care did not see worsening conditions. Now, you may say, well, even if their condition is not getting worse, isn't it still better for them to be able to get care and thus solvency? Now, this is a great question, and I think that the answer actually yields a response that disproves that Medicare-for-All will actually be the mechanism to solve this issue. The point is that in a world where Medicare-for-All exists, there is going to be a huge strain on the medical industry, namely where people seeking elective operations or operations of low urgency are putting great strain on the medical industry. Again, we have already proven why this will occur. As such, it is largely the case that people who do want to get care and not forego their care will have the de jure ability to do so, but will they actually have the de facto ability? The answer is no. To the extent that there exists a huge strain on the medical industry, even if people are legally able to get access to the care that they need, it is likely the case that the supply is already suffering because prices are already negotiated to lower levels, but also that resources are likely crowded out. That is to say, the new strain that exists will ultimately prevent capital from being mobilized to the people who need care. And even if it is the case that these people are able to get their hands on care, it is likely the case that they have had to wait and suffer to the same extent that they would in the status quo, where they would have to first raise the money to fund their treatment. So why is this the case? Because even if these individuals don't technically have any explicit costs to getting access to this care, with a greater strain on the medical industry and a greater effort and time that has to be put in to get access to care, it is likely the case that implicit costs rise. In other words, people have to dedicate huge amounts of time to getting healthcare and begin to actually have incredibly high opportunity costs to a much greater extent than those that already exist in the market due to the fact that the resources of the healthcare industry, like any, are limited. As such, this can mean that people must give up potential opportunities to make a wage or continue to suffer in pain that can potentially lead to worse disease and only further strain on the medical industry, meaning that we get this vicious cycle. Again, this is logical argumentation, but there's also empirical evidence for this. In a report titled Waiting Your Turn, Wait Times for Healthcare in Canada 2019 report, researchers Bachus Bora and Mackenzie Moore find that first, wait times in Canada have increased, but more importantly, that the impact of these greater strains and waiting times comes in the form of worsening conditions and socioeconomic damages that only add further strain. Secondarily, it proves that insofar as there exists some amount of strain, this small amount of strain can easily link into much larger strains, meaning that if we were to play around and say that someone could mitigate this argument, it still stands that marginal amounts of crowding out can link into major negative impacts for people. So what does all of this mean? Well, we can first recognize that Oliver significantly overplays the fact that people may forego care due to cost, especially because if people forego care, there are more nuanced questions that have to be asked, so that we may know if these foregoed medical services are leading to worsening health conditions. This question is largely unanswered by Oliver, but we actually provide it using his own source. Second, what is the comparative in a world with Medicare-for-All? Is it the case that Medicare-for-All will solve this issue of people foregoing care? It is likely the case that people may still be incentivized to forego care when the opportunity costs rise as the strain on the medical industry increases. So even if we were to give Oliver the benefit of the doubt and say that any foregoing of medical care is bad, it is likely the case that foregone medical care continues in his world as well. Now, Oliver does try to address this in an earlier point when he says that there will have to be a balance struck in terms of wages and payment. But it's also the case that even if wages and payments are preventing any type of bankruptcy, there is the issue of the uptick in demand that will lead to a crowding out of non-monetary medical resources. Things like hospital beds, office spaces, capital for drug production, and general capital that can be used to expand medical services. Now, some may claim that the government can just spend more, but recognize that at the point at which the government begins to overspend, there is going to be a huge issue of crowding out of investment, leading to a greater difficulty for capital formation in the general economy, which presumably would impact the medical industry as well. So why is this true? When the government spends to such large degrees, especially to the level of Medicare-for-All, there will have to be a significant amount of deficit spending. The result is thus that competition in the loanable funds market increases, as the demand increases with government borrowing, and as such, interest rates take a general rise. The result? The cost of debt instruments that can be used for capital formation begins to increase, making it difficult for healthcare providers to get access to the capital that they need to expand their services. This crowding out effect has been long studied, and a great piece that explains it comes from Matthew D. Mitchell and Jacquina R. DeBenham's working paper titled "In the Long Run, We're All Crowded Out," which, with the rest of my resources, is linked in the description below.
Then there is the final big criticism of Medicare-for-All, which involves choice. Specifically, that it would take away our ability to choose the sort of health coverage that we receive. But the fact is our current system limits Americans' choices far more than it expands them. For starters, as a practical matter, most of us don't choose our health insurance. We get what we get through our employer. And because of that, choices like changing jobs can become significantly harder. And not just that. Oftentimes, your choice of doctors and hospitals is severely limited by which ones your insurance will cover. Going out of your insurance network can be prohibitively expensive. That is why people bend over backwards to stay in network. And even when they do that, it can still all go horribly wrong.
Again, I think that Oliver makes a common flaw here in not understanding that simply pointing to issues in the status quo doesn't exclusively advance any advocacy for Medicare-for-All. The argument is not that the current system has unlimited choices for people, but rather that Medicare-for-All is comparatively worse than the status quo and that it limits choices to an even greater degree. That is to say, we could buy Oliver's own argumentation here and say that everything he says is true. Even if we buy his own arguments here, it only indirectly explains why Medicare-for-All is a solution. And as I should remind, it is the case that more market-based reforms can expand choice. But let's answer some comparative questions to understand why Medicare-for-All actually limits choice. Even if we buy Oliver's own argument that people don't have that many options in terms of hospitals due to in-network and out-of-network issues in the status quo, the removal of in-network and out-of-network, mixed with provider payment rate shifts and lower prices, as well as major consolidation, will lead to less competition among healthcare providers and thus less choice. Why is this the case? First, we can recognize the fact that with increased demand and an inability to charge higher prices, smaller healthcare providers will soon lose competitive advantage within the market, namely that they are incentivized to exit the market due to rising average total costs and falling prices. As such, it is likely the case that consolidation occurs with larger providers and facilities, leading to higher concentration ratios in the healthcare market. So why is this bad? If you have a greater concentration ratio of healthcare providers, accountability for these providers decreases. In essence, in a perfect world, bad healthcare providers face the difficulty of losing potential consumers. While certainly there are more forms of inelastic services such as emergency operations, it is likely the case that for day-to-day operations such as diagnosis, preventative care, and checkups, if people are unhappy with their current provider, they can switch. Secondly, monopoly market costs are oftentimes higher, leading to greater costs on the system. This is also empirically supported. Healthcare consolidation is already occurring as costs rise, namely that according to the American Medical Association, the number of employed physicians has overtaken the number of self-employed physicians since 2012. In fact, the Federal Trade Commission found that this has led to greater market concentration and, as such, higher costs by nearly 15%. Additionally, researcher Zure Song out of Harvard Medical School found that Medicare-for-All would likely lead to even greater industry consolidation, going in the complete opposite direction that we want. Now, let's say that reimbursement rates were largely the same. Even if this was the case, the access to capital to expand services would decrease as government spending and crowding out would take effect, likely leading to higher costs for the establishment of new medical practices and only creating greater barriers to entry and further monopolization. As such, the best case for John Oliver here is a wash on whether the status quo or Medicare for All will expand choice, or at worst, preserve as much choice as possible. Therefore, even if you remove in-network and out-of-network issues, you only introduce a new problem with regards to healthcare provider consolidation.
Anyone who is resistant to significant change is going to have to own all the flaws of our current system. One in which, when Americans get sick, they can find themselves comparison shopping with a burst appendix, flipping a coin between life-saving medications, and praying they can come up with a catchy enough hashtag to cover their care.
Again, this just gets back to the theme that if we want change, we can achieve it. The question is why Medicare for All is the proper change. Now, as I've discussed throughout the video, we don't get an explanation as to why Medicare for All is the best change, and I've consistently mentioned how there are better ways which involve more market-based approaches. So, by this point, I think that it would be blasphemous to simply ignore a proper discussion of these market-based alternatives and a bit of a comparative analysis with the current status quo and Medicare for All. Now, let's start with the characterization and conceptualization of the healthcare market. To qualify, the healthcare market doesn't operate in a perfectly symmetrical manner with traditional markets like agriculture or luxury goods, for instance. There is an element of the healthcare market which breeds certain market externalities that require certain levels of government intervention. For instance, if someone gets vaccinated, this has a huge positive impact upon other people by virtue of the fact that this person doesn't risk spreading a disease. As such, there are third parties who don't bear a cost but receive a benefit. In the same way that if fire departments were privatized, certain individuals would bear the cost of helping other individuals. Think if you were to call the fire department to save your entire neighborhood from a fire, eventually people would deflect responsibility to others in a bystander effect-like manner. This is what is known as a positive market externality, and there are many ways of accounting for it, such as redefining property rights, not just physical property but also bodily autonomy or subsidies. Second, there are cases of people not being able to actually shop around for healthcare in the traditional market manner, such as somebody being rolled into the ER unconscious, hence things like the Emergency Medical Treatment and Active Labor Act of 1986, which require hospitals that accept Medicare beneficiaries to treat patients in the ER regardless of citizenship, legal status, or ability to pay. But more importantly, the point to get at is that certain government regulations are necessary, as we can see. Now, that being said, it doesn't mean that market principles don't apply to healthcare, nor does it mean that the current issues with healthcare are only solvable through direct government regulation or takeover. To best understand how market principles can be applied to address the current issues we face with the healthcare sector, we have to start with some conceptualizations. In the status quo, people, when receiving insurance from their employer, are often incentivized to over-insure. Why is this the case? Say that your employer did not cover your insurance premiums. In this case, you receive your wage and are subject to federal income taxes, possibly state income taxes and FICA taxes. As such, the money that you have to cover premiums is lower. Now, take the converse. In this case, let's say the equivalent that you would have directed towards insurance premiums is instead paid by your employer. All of these taxes are now set aside. The amount of money that you would have owed in taxes is now exempt, with the amount of the subsidy being the amount of money that you would be expected to pay to the government in taxes, but that is now not collected. So what does this mean? People can reduce their tax liability by purchasing more employer-sponsored health insurance, meaning that individuals are often incentivized to over-insure and act in wasteful manners when there could be opportunity costs with the money that is spent on these generous packages, but have no consequences on health outcomes, the typical case of moral hazard. But we can actually change this. Instead, people can have the same tax relief, but instead avoid the hassle of more expensive insurance. How? Start with the status quo. If you make $100, using simple numbers for instance, and your tax is 20%, if you have the money paid by an employer directly for premiums, you retain that $100. If you instead collect the wage and then use after-tax dollars to buy healthcare, you lose $20, meaning the exemption, or subsidy in this case, is equal to $20. Therefore, using this example, you would be incentivized to purchase $100 worth of healthcare rather than $90, for instance. If your employer only spent $90, you would have $10 that would be subject to a tax, meaning that you would only retain $98 in the case where you only spent $90. So what is the alternative? Instead of the subsidy being through an exemption on employer funding of health insurance, it would be the same subsidy, $20, but would be a tax credit that reduces your tax liability. If an individual decided they want a less generous package, they would have more income to cover any out-of-pocket costs since it's a fixed dollar subsidy. All you really need to know is that restructuring the subsidy can result in people having the same tax relief and with the same coverage, but more financial freedom. If people opt for lower valued coverage, they receive more money. Now, Obamacare tried a similar policy, but decided to phase it out over time, resulting in a marginal implicit tax rate as people made more. Essentially, the more money made, the smaller the subsidy, the greater the tax liability, creating a conflict. This also wasn't helped by issues of the employer mandate. And this wasn't anything mitigatory. In fact, the salience is empirically shown. As detailed by the Goodman Institute, University of Chicago economist Casey Mulligan found that Obamacare imposed the third largest increase in marginal tax rates in the past 70 years. Now, the plan that I've just described to you is actually nothing new. It is a product of the work of John C. Goodman, which is called the Universal Health Tax Credit, and I truly recommend you guys check out his work. So let's get into a bit more detail. So how much should this tax credit be? The tax credit should skew the cost-benefit analysis of someone who is uninsured and unable to afford uninsured healthcare, meaning we can take the worst-case scenario and see how the system would handle it. That is, when people are uninsured, they weigh the value of free care to the care that they would get from private insurance. If a person has a tax credit to purchase $5,000 worth of private insurance, but the free care equivalent would be $6,000 if they simply forego the tax credit, people will choose being uninsured in nearly every circumstance. Therefore, the tax credit should be equal to the amount of money spent on free care from public and private sources for a given year. Therefore, the new cost-benefit analysis of an individual is this. They can choose to be uninsured and, as a result, forego the tax credit, increasing their tax liability by the amount of free care that they would generally be paying into, or then choose to accept the reduced tax liability and buy private insurance. So what would be done with this money? The amount that would have been originally used to fund the individual purchase of private insurance would be used by the government to fund a local safety net healthcare provider, which is simply a provider that people who are uninsured, on Medicaid, or other vulnerable patients can use. The opposite can also apply. Let's say that every individual were to purchase private insurance. The safety net practice would no longer need to cover the cost of free care, because nobody is using free care. And as such, the balance works between moving funds to individuals, to local safety net practices, and back and forth as coverage changes. Secondarily, the credit is very malleable given the way willingness to pay works. For instance, let's say that the cost of care to an insurance provider is $5,000 for an individual. This means that the credit must be at least $5,000, since if the average person pays in $2,000, for instance, but the average person costs $5,000 based on actuarial risk, then insurance companies will have capital deficiencies. However, if this is the case, then safety net providers will be willing to give up $5,000 due to the fact that if the cost of free care is $5,000 for that individual, as found by the insurance company, them giving up $5,000 to the government is worth it, considering that they are no longer having to cover an individual that would cost them that $5,000. That is, safety net providers will give up an amount equal to providing care for that individual, most likely due to opportunity cost, since there is the explicit cost of the care, $5,000, but also the implicit cost of the care. As a result, the government could easily save money on safety net expenditures. What this means is that as premium rise, so does the tax credit, incentivizing people to enroll in the individual market and avoiding the issues of adverse selection in which only unhealthy people pay into these programs. But why? Most individuals would presumably conclude the government would have to fund this tax credit from creation. However, as according to the Goodman Institute, the vast majority of money in the form of safety net expenditures comes from federal funds, meaning that more people using private insurance is a lower liability to the government. Therefore, the government could fund these tax credits to a much greater amount. Secondarily, a large amount of free care is already paid for by the government, meaning that lower costs of free care create a revenue-neutral situation, given that for every dollar spent on the private insurance tax credit, there's one less dollar spent on free care. Now, some might say that people who are uninsured or vulnerable are still expected to make payments or meet some amount of payments, and this is true. But the following example shows that in the absolute worst case, where anybody that is uninsured has no money to pay for care, the system and apparatus still works. However, the key is that even in other cases, the following apparatus still works by simply allowing the government to only reapportion a certain percentage of money towards local community safety net providers, and the rest towards other programs like an earned income tax credit expansion or other effective policy. Secondarily, if needed, they can move the money to subsidize health savings accounts for lower income individuals. So even if it is the case that people who are uninsured or vulnerable are still expected to make some payments, the government can reapportion accordingly. The second policy on the demand side would be new regulation changes to health savings accounts. So why do these matter? Health savings accounts are forms of self-insurance, namely where individuals are able to save money for any potential medical expense. Insurance, on the other hand, is controlled by a third party. We want to strike a balance between self-insurance, health savings accounts, and insurance by the hands of a third party, to ensure that there isn't overspending when it comes to third-party insurance, as we've already explained, but also that people are not too reliant on out-of-pocket costs, and insurance providers still have adequate capital to boost and improve coverage. Now, since there is a tax credit provided for individuals to fund a portion of the purchase of third-party insurance, with the rest being after tax, health savings accounts should also be after tax with regards to deposits to ensure that people are not overly relying on out-of-pocket costs by instead putting more money into a health savings account and less into a third-party insurer. Therefore, the HSA is after tax with regards to deposits and tax-free with regards to withdrawals for health-related concerns during the insurance period and tax-free with regards to withdrawals for any other purpose. Secondarily, HSAs should remain flexible such that they're able to fit the needs of any certain plan. That is, easing IRS criteria on what is valid for HSA funding in terms of procedures. What does this look like? As found in a study by Value Penguin, nearly 80% of plans were ineligible for HSAs because the plans were, quote, too generous. Easing these regulations could clearly allow individuals to utilize HSAs to better extents. Again, John C. Goodman does great work in describing the way that these HSAs would operate concomitantly with a tax credit. Now, this covers a bit of the demand side, so what about the supply side? The key to the supply side is quite simple. The cost of care should be lowered by a two-factor method, boosting the supply by virtue of the mechanisms behind each individual provider, that is, increasing their individual capacity to treat patients, and by increasing the raw number of providers in the market as well. So where do we start? There are a plethora of structural changes to the way that the US government approaches healthcare that can allow them to expand healthcare services. First is expanding access to telemedicine. Telemedicine essentially allows individuals to receive medical care remotely, thereby allowing individuals to skip any waiting lines, traffic, and simply provide better convenience for more vulnerable patients. However, importantly, services like Medicare only pay for these services under very limited circumstances, namely that generally patients who live in rural areas are eligible. However, given the positive impacts of telehealth, it should be the case that it can be expanded to other individuals. This benefit is empirically seen as well. As reported by the American Journal of Medical Colleges, researchers Karen Donnellan et al. Found that telemedicine has provided enhanced follow-ups for individuals and have provided individuals with a better alternative to office visits. In fact, patients were so satisfied that many, as according to the study, were willing to pay co-payments for these services. Even if we need more evidence, as reported by Dr. Jay Portnoy in the Journal of Allergy and Clinical Immunology in Practice, a systemic review of literature studying the impacts of telemedicine on specifically treating asthma found that telemedicine contributed to better asthma control and quality of life in comparison to usual care. Now, granted, telemedicine still has room for development, as care continuity is a huge factor that telemedicine should seek to equalize relative to usual care. However, as more healthcare providers adopt telemedicine, they will be more incentivized to keep better data on their patients and ensure that providers have the necessary medical history of patients. Additionally, with regards to healthcare providers, major decreases in the number of regulations have to be made. As I've mentioned earlier in the video, these regulations cost healthcare providers the ability to redirect full-time equivalents to care delivery roles, rather moving them towards administrative management, lowering the supply of medical care to individuals, and creating an earlier tipping point at which healthcare providers begin to feel a strain on their services. Granted, there are numerous regulations that have to be considered and systemically reviewed, but it is still the case that there are numerous regulations that have to be removed. Other reforms that could particularly work are some elements of the healthcare choices proposal created by the Health Policy Consensus Group. For instance, removing the federal essential health benefits requirements would allow states to tailor insurance regulations over minimum requirements for insurance coverage towards different state conditions and, as such, remove the chance that premiums rise. Why is this the case? When per-beneficiary coverage expands, so do premiums. Namely, when the base plan becomes more comprehensive, there is more cost per beneficiary on the hands of insurance providers. Hence, average cost per beneficiary increases, average pay-in must increase as well, especially because all patients are charged the same in a world where different rates cannot be charged for people with pre-existing conditions. For instance, some states may have better mental health services available and generally don't suffer from issues of mental health to a comparative degree with other states, and when they do, already have mechanisms in place to deal with them. This could make something like Part E of the essential health benefits with regards to behavioral treatment largely unnecessary. Now, this is empirically seen as well. Analysis by Edmund Heiselmeyer and Doug Badger found that the federal requirement was responsible for a near 5% to 11% increase in premiums depending on the state. When factoring in the fact that even marginal changes are particularly impactful for people of lower income status, it comes out to the fact that even marginal shifts in premiums are enough to trigger large-scale negative impacts on those who are lower income. So even if one were to argue that the quality sees a huge boost as a result of these minimum requirements, it doesn't matter to the extent that these positive impacts aren't accessed by people of the lowest income status. Additionally, repeal of the medical loss ratio requirement could allow insurers to expand to greater amounts. So why is this the case? Under this requirement, insurers can only spend a certain percentage of premium income on limiting claim payments. However, at the point at which this happens, administrative costs take a jump because when insurers want to be able to expand, they need capital to be able to do so. Now, limiting claim payments allows them to put in some money to avoid a much larger loss of capital from negotiations, which only decreases the expansion of existing insurers and the entrance of new insurers by virtue of the inability to limit the administrative costs that come with this negotiation. The reason is because at the point at which a claim is filed and approved, the health insurer-health provider tug-of-war begins. Now, the MLR dictates that insurance providers spend roughly 80% on claims and quality improvement, with the remaining 20% having room for administrative costs. However, given that expansion often requires higher than average administrative costs due to licensing dues, marketing, administrative infrastructure, and other fixed costs, it is likely the case that such limits prevent expansion or dealing with the sunk costs of entering insurers. Moreover, under the Healthcare Choices proposal, states would have block grants, namely funded from the previous federal funding of Obamacare, and would be able to use these grants to create better risk adjustment mechanisms that encourage specializations in terms of insurance plans and treat the race to the bottom that has occurred under Obamacare rules and regulations. Additionally, this would be checked by the government such that people with worse health conditions see improving health outcomes. Why? Under the status quo, insurers on the Obamacare exchange are incentivized to tailor plans that discourage people with pre-existing conditions from paying in, and encourage more people from healthier backgrounds to pay in. The reason? Patients with pre-existing conditions, as according to a report by researcher Michael F. Cannon, have essentially been losses for insurance providers. That is, the value of their claims has been much higher than the amount that they end up paying in terms of coverage. To put another way, the marginal cost of an unhealthy patient will typically be greater than the marginal revenue of that patient, given that premiums are uniform under new regulations. And the cost-sharing reduction subsidies that were created by Obamacare have still not been enough. As a result, insurers have been incentivized to tailor plans in terms of their services covered, as well as the level of premiums and deductibles, such that people with pre-existing conditions don't buy in. Namely, that people who are healthier generally pay more into low-premium, high-deductible plans, given the fact that they are less likely to need healthcare and thus are more willing to avoid the sunk cost of the monthly premium. As a result, this has led to health insurance providers to lower payment to providers and limit their networks only to the providers that are willing to take such low fees as a way to ensure that their premiums are low enough. So even if it is the case that people with pre-existing conditions opt in, the quality of coverage has been below average. And this has been empirically proven as well. A study funded by the Robert Wood Johnson Foundation has found and implied that narrow networks are primarily the result of insurers only looking to work with providers that can fit their plan of discouraging individuals with pre-existing conditions and encouraging healthier individuals to pay in. Need more evidence? A study by Avalier found that insurance plans on the Obamacare exchange included 34% lower providers than non-exchange plans. Therefore, to correct for this, states can create specialized insurance plans that offer benefits for people with pre-existing conditions, helping offset the issue of adverse selection and ensure that for healthy individuals, premiums don't rise too high, working in conjunction with the previously mentioned tax credit to ensure even more security for these individuals. This would first provide the solvency for people who have pre-existing conditions, and second, lower premiums for people who are healthy, providing more coverage for individuals and better quality coverage in comparison to the status quo. Now, some might argue that these high-risk pools might be too expensive, as the Kaiser Family Foundation discusses that before the ACA, nearly 35 states had high-risk pools, and that for many, the cost was simply too high in terms of keeping premiums low. But there are two responses to this. First, this existed in a world where insurers could deny coverage to people with pre-existing conditions outright. In essence, in the previous world, it was the fact that high-risk pools took a much greater role. In this case, insurers cannot discriminate based on pre-existing conditions, meaning that the goal of these high-risk pools would rather to be offset the adverse selection that ends up taking place. That is, insurers can still take in people who are unhealthy, but the simple fact is that we want to control the influx such that the marginal cost of these unhealthy people doesn't outweigh any marginal revenue that could be brought in from healthy enrollees. As such, insurers will still have unhealthy enrollees, but to a much smaller volume, meaning that the cost is likely not going to be so high due to the spread. Second, even if the cost is high, it is unclear as to why it is comparatively worse than a public option or Medicare-for-All. The healthcare choices proposal makes clear that previous ACA funding would be redirected towards state high-risk pools, so it is not the case that new revenue has to be created. Secondarily, paired with greater drug innovation, health expenditures can likely decrease as chronic diseases see a greater chance of being stopped by new drug innovation. So even if we want to buy the fact that the cost will still be similar to the pre-ACA world, it gets outweighed by numerous other factors. In the worst case, it's still a comparatively better option. So does all of this work? Well, as according to a study by the Center for Health and Economy, the healthcare choices proposal would lower premiums, ensure roughly the same amount of people as Obamacare, and would still provide solvency for individuals with pre-existing conditions, achieving many of the same benefits at a lower cost in comparison to Obamacare. While some elements would have to be thoroughly reviewed, many of these structures and proposals that have been brought up can lead to better outcomes. However, market-based solutions don't just exist on the insurance side, but also on the innovation side, namely reducing many regulations on the hands of the FDA. In fact, when researcher Doug Bandow studied FDA regulations, he found that the average cost of developing a drug ran at $359 million, with FDA regulations responsible for nearly half of the costs. While it is the case that the FDA can prevent harmful drugs from entering the market, they also don't need to accomplish this with applications that cover 100,000 pages and can take up to a decade for approval. Now, the weighing comes pretty clear: bad drugs or good drugs. Presumably, there are bad drugs that are stopped with FDA regulations over efficacy concerns, and good drugs as well. However, the simple fact is that you can still stop bad drugs with a lower bureaucratic process. But even if we are to buy that there are some lives lost from bad drugs, it doesn't stop the overall impact that good drugs have. That is, when the FDA acts in more risk-averse manners, like any federal agency, it must standardize such a policy such that good drugs are also worsened. However, given the earlier fact that 40% of the market suffers from incurable chronic diseases and that there exist significant barriers to entry due to FDA regulations, it is likely the case that people also lose lives from a lack of good drug development. This is also empirically and historically noted. As elaborated upon by researcher Doug Bandow when talking about the FDA's imposed regulatory climate, quote, "As a result, families with a member suffering from Alzheimer's disease have been frustrated by the agency's refusal to authorize the use of the drug THA, available in other nations, despite evidence that it helps 4 of 10 patients who take it. Delays in bringing propranolol, a beta blocker for use in treating angina and hypertension, to the US market may have cost 100,000 lives. Nearly as many have perished from the lack of availability of the antibacterial Depra. Thousands have also died waiting for misoprostol, a drug for gastric ulcers, and streptokinase and TPA for heart conditions. Equally costly has been the delay in bringing anti-AIDS drugs such as AZT to the market. Only enormous pressure from AIDS activists and Vice President Dan Quayle's Competitiveness Council caused the FDA to speed up trials of potentially life-extending drugs. But let's say that we don't buy this evidence. Maybe you want a better weighing of the positives and negatives of the FDA, or maybe you don't trust the evidence. Well, according to the FDA review, an offshoot of the Independent Institute, numerous bodies of evidence suggest that FDA regulations have done more harm than good. The first is a comparative analysis of pre- and post-1962 health outcomes due to FDA regulations by researcher Sam Peltzman. Why 1962? In 1962, the Kefauver-Harris amendments to the 1938 Food, Drug, and Cosmetics Act were passed, adding to the proof of safety requirement a proof of efficacy requirement. Now, the Kefauver-Harris amendments were not categorically bad, and their restrictions on false advertising and encouragement of symmetrical information were rather good. However, the testing requirements behind drugs proved to be where the majority of health outcomes were being weighed pre- and post-1962. As researcher Sam Peltzman concluded, the number of new drug introductions post-1962 was significantly lower than the projected average under the condition that the Kefauver-Harris amendments had not been passed. Now, some might say that the decrease in the drugs is justified, given that bad drugs are no longer being created. Well, Peltzman actually studied this as well. He ultimately concluded that there was little evidence that ineffective drugs did not largely decline after 1962. A review of the study by the American Enterprise Institute for Public Policy Research in 1983 also concluded that the decline in drug production was not focused on ineffective drugs. So why does this make sense? Well, in the pre-1962 world, the tort system, simple short regulations, and voluntary institutions helped prevent the production of ineffective drugs, and there were already accountability mechanisms in existence that didn't boost the cost of drug production. Secondarily, the FDA has an incentive to delay drug approval. Why is this the case? If a person passes away due to a faulty drug, the blame falls on the FDA and the drug producer in question. Conversely, if a person passes away due to a drug delay, the FDA sees asymmetric backlash, namely less backlash, where individuals are unlikely to blame drug delay because they aren't completely aware of the inner workings of the FDA and what drugs should have been approved or disapproved. To avoid backlash, the FDA will rather take a risk-averse stance, despite the fact that symmetrically they are contributing to the death of an individual. And thus, while the FDA incentive may exist regardless of the number of regulations, their capacity to insulate themselves from blame using the high proof of efficacy requirement doesn't exist. And there is more. As found by the FDA review, off-label drug use, despite not being approved by the FDA for the efficacy of that specific use, see large amounts of success despite not facing the same screenings as drugs for their stated use. Why does this make sense? This is due to the fact that even if the FDA is not the main regulatory body in question, the general safety of the drug has already been tested. But additionally, healthcare providers can use sources like AMA drug evaluations or the American Hospital Formulary Service drug information and other sources that already empower these individuals to make proper decisions, going back to the voluntary organizations that exist and prevent the dangerous use of drugs. As such, it is not the case that the FDA is the only organization that can properly evaluate the efficacy and safety of a drug, so placing a monopoly in their hand beyond basic and necessary safety precautions simply opens the door to redundancy, drug delay, and worse health outcomes. Now, I think that I've provided some amount of comparative with Medicare-for-All. The question is also the other major policy proposal, which in this case is the public option. The public option, as supported by more moderate Democrats, would still contribute to greater amounts of deficits, specifically by nearly $700 billion over 10 years by researchers Tom Church, Daniel L. Heil, and Lan-Hee J. Chen out of Stanford University, with long-term projections pegging it at 30% of the GDP in terms of debt contributions and as a result, still triggering the macroeconomic effects of crowding out. Of course, it likely wouldn't raise interest rates on capital formation debt instruments to the extent that Medicare-for-All would. However, given that you most likely want a generous public option, people will definitely be switching over and thus causing insurance providers to rely more on the expansion of capital to cover the administrative costs that are also restricted under the loss ratio of Obamacare. However, the larger issue comes with a different type of crowding out that occurs with the public option. When the public option is created, presumably it will offer a very generous package of benefits for a lower cost, primarily to provide solvency and security for the previously uninsured and underinsured. But here's the issue. If the public option is actually an effective tool for providing insurance and is generous, people under private insurance regimes, even if not needing to, are likely to switch over to said public option. As a result, with smaller risk pools, private insurers will be forced to raise premiums to cover the lack of pay-in from previous members, and as such lead to more people leaving and entering the public option, driving a crowding out effect where private insurance is essentially killed. The issue with this is, therefore, that if this is the case, and the better case scenario where the public option isn't too generous, there are still going to be some people left on private insurance plans, which are likely to simply spell higher premiums for these individuals. So what does this mean? If the public option is likely to continue to work, it needs to raise premiums or reduce generosity, as this means that the marginal cost of additional enrollees will not outweigh the marginal revenue, likely leading to the issue of underfunding for the program, austerity programs that cut benefits and reduce quality, or increases in the pay-in that act counterintuitively to offering more generous packages to the poor. If it continues its generosity, you simply enter the moral hazard territory that occurs with the extreme generosity of the Medicare-for-All proposal, and price signals become inoperational. This is empirically proven as well. According to researchers David M. Cutler and Jonathan Gruber, while crowding out isn't caused by employers not offering insurance coverage, but there are rising premiums, it does occur with regards to public insurance being far more beneficial than private insurance, and as a result, the weighing comes down to the option of public insurance. The researchers studied the expansion and eligibility of Medicaid from 1987 to 1992, and found that in the case of expanded public insurance, nearly 50% of the increase was due to people taking up the public insurance option, not including people who were taking up conditional coverage, at which point the estimated increase to 77%. So there are really two worlds that we are dealing with in the case of the public option. First is an incremental destruction of the private insurance industry, at which point you enter the world of moral hazard that is afforded under incredibly generous governmental plans. Because presumably, if the private insurance industry can't compete with it, it is incredibly generous. Or not providing solvency for those who are underinsured as to prevent this moral hazard, at which point it most likely won't be an effective social safety net. Because at the point at which generosity exists, the crowding out cycle begins, premiums rise, and enrollees into the public option increase. Overall, I think that this market-based approach works within economic incentives and minimizes trade-offs. That is to say, unlike the public option or Medicare-for-All, there is the general issue that incentives lead to macroeconomic changes not predicted by the general policy change. A public option could be used to offer solvency for those who are low income. However, it sacrifices also increasing enrollment due to widespread eligibility, and thus creating externalities with the rest of the private insurance industry and people who may still remain on those plans in the best and probably impossible scenario, in which the premium spiral triggered from this crowding effect doesn't take place. A Medicare-for-All proposal leads to a worse case of simply encouraging overuse and driving up costs that only strain the medical industry even further through the crowding out that occurs under large-scale government expenditures, having an externality upon healthcare providers looking to expand quality and coverage. But yeah, that is just my opinion, and I encourage you to offer your own thoughts in the comments section and tell me how stupid you think I may be. But otherwise, thanks for watching, and I'll catch you in the next video.